Does there need to be more of an acknowledgement that innovation is as important as reform, and there should be some government funding and maybe some outside grants or incentives to help people do that? I mean, certainly we see that in a limited way, but should that be more of a focus as part of this change?
I always find those interesting in how they're applied. And again, it's the facilities that have the grant writers and the like that actually can make use of those funds.
Right.
And so, I mean, obviously, then you should have the appropriate grant writers to write things. But I think those innovation funds are good. We're looking at some ourselves right now, potentially, to use, but still, they tend to go to places that are, that have the people that are geared up for that type of stuff. And the other side is in the public health area. But I think we're trying to make a consumer market for a service that isn't a consumer-based market. And that's a real tough one. And I think you see the legislation is getting higher and higher. It's okay, we'll tax soda. Okay, we'll tax beer, God forbid. And, we'll just keep on going. So I think we have to look at it differently, but I don't think it's going to happen for the next few years.
I think some of the challenge we have in trying to make a consumer product is it's very different from buying an automobile or buying your next computer. You're suddenly sick and you don't know where to go. And we don't, as health plans, do a very good job of helping people select their provider. You want to find a provider on the website and what you see. Well, you see what college they went to and what their address is, a couple of things, short of taking them off the patent because they have they had a problem with their licensure. But we don't do a very good job showing them quality. And I've been the rounds with the legal department about how much we can put out there. Our chief medical officer would love to go to 1 through 5 stars on all the doctors. That doesn't work very well. And I said, well, just how about, I'm just trying to brainstorm here, how about letting our participants talk about the providers on the website, let them provide some content. Well, all they're going to say is how long they waited in the waiting room. The guy was a nice guy, he happens to have a higher death rate than the rest, but they don't know that. And so we don't do a very good job of helping people select their providers. And I think that's a challenge we need to help overcome.
Well, part of the problem is that we have four hospital systems. The tertiary hospital takes the tougher cases. They have the higher morbidity rates. So it still has to be risk adjusted.
Right.
And sometimes those, you comparers don't do that. Right. So, you go to a cancer doc or, a physician who most of his patients may be dying. How do you judge quality based on that? That is just tough.
Quality, if they're trying to be a prudent consumer, if I go to hospital A, what's it going to cost to have a appendectomy versus if I go to hospital B?
Yes.
We can't provide that very well. Because we don't know what codes are going to build, even if we did.
Right. One of those first forays into that is that's probably affecting us as we speak is the family-based purchasing model where we're going to lose 1% of our DRG payments in 2012 potentially, with the ability to gain it back based on patient quality and satisfaction scores, which are publicly reported. So, it's actually happening. Our baseline years were back in 2009, and we're actually being measured right now as we speak up through March of 2012. And then in October, we're going to find out the results, and it's going to affect our budget in a positive way. It's a zero-sum game, too, so there's going to be winners and losers. And that is publicly reported. So I think that's going to actually help the consumer do some type of comparison. But it won't get to the cost piece. This is more perception.
What you have to do as a hospital, we have a team of people, a multidisciplinary team, put together just to raise HCAP scores. And that's what we're doing. We're putting them together because we want to be the winners. We want to be on the upper side, not on the lower side. But that's what you have to do. And when you do that on a zero-sum game, okay, you may be raising the water, but the other guy may be raising the water out as well.
You have to raise it faster.
Faster, right? Exactly. You have to raise it faster than the next guy.
So, one of the other things we see kind of driving this market, we've touched on it a little, is the change in the apportioning of risk, the change in the way revenue is received, all seems at some point to favor scale in the long run. larger systems can spread more risk around, larger systems can, spend more time finding these grants, more time looking for an innovation. How important is scale in the long run here? And let me marry that up with, we increasingly see payers and providers, moving beyond partnering and really becoming one business. And we kind of think of this as the ascension of the IDN in the market. The large integrated delivery networks seem to be doing better from a profitability perspective, and they seem to be growing faster. So can you comment a little bit about how important is scale in this market, and how are you guys looking at that? And is it likely in your mind that down the road we'll see more integrated networks, more co-joint payer providers as this market evolves?
Yes.
Yes.
I can see as a health system, we're looking, we've expanded. We bought 2 hospitals in the last 3 years.
Yeah.
So we're expanding there. We're beginning to talk to the payers more, probably more than I know myself.
Yeah.
So that's occurring. But you look at the Kaisers and the Geisingers, they seem to kind of have the model that, depending on what your local area has. And I really think we're going to be seeing a shift towards that type of model.
Well, yeah,
I want to see my system getting into that.
I kind of characterize that as it's a lot less painful to move money from one pocket to another than it is to take it out of your pocket and hand it away. And there seems to be a certain amount of that going on in these institutions.
Yeah, so in our market, we'll have to.
But but that's going to happen. It probably should happen to some degree, but isn't that a defensive tactic and not an offensive tactic? That's not innovative. And so is it really going to get us anywhere in the long term? So I think that has to be, this is just a defensive pullback and, more people inside the fort.
Right.
And so that's not going to bring up an open system. It's not going to be competitive. It's just going to be regionalized fortresses that you create.
I think, like Rick said, we're doing the same strategy of we're going to growth mode and affiliation mode. But I think, through the use of technology, though, I think across these regions, we can share evidence-based medicine. We can share what's the best order set and all these types of things that I think can improve care. It's going to take some time to get these delivered across these regions in our organization, but if we start having the physicians all use these best practices, I think we can make a difference. It's going to take time, but some of the growth is going to allow us to do that in our organization.
So I think you're saying some of this error funding stuff has actually helped. I mean, it's making us make those moves, so somebody had a good idea there.
And quite honestly, we did not have to work as fast as we are if we didn't have the funding to do that.
Well, we have about 5 minutes left, and I wanted to leave an opportunity for you folks in the audience to have a couple questions. There are, I think, 2 microphones set up here. If you have a question for our panelists, please feel free to just come on up. And, oh, great, okay. Good morning.
Good morning. There are 2 issues that you raised that I would like to understand a little bit better. I got the impression that you're concerned that patients have the right to opt out. If there weren't any consequences to payers having information for the patient, they might be willing to opt in. But right now, payers create penalties for individual patients if they have information that might damage their ability to have insurance. So if you could make it so that there wasn't a penalty, then I think you might have a much greater incentive for patients to opt in.
No, that's a great point. And I was kind of alluding to it as we get into this accountable care and healthcare reform kind of model, where I would hope some of those rules are different. But you're right on. And actually, in our organization, when I mentioned about us sharing this information about all of our patients with the payer, we went through those same things. Our biggest concern is how are they going to use this data against us? Start ratcheting down our reimbursement. I mean, well, ultimately we're thinking how is this best for the patient? We got to put that out here, right? And then it was that next tier of how's this going to use against us, to your point.
The other related issue to that, which I wish you would address, is the whole issue of sharing psychiatric and substance abuse information. That is an area where we've created all these wonderful networks, and there's state as well as federal regulations that prevent the sharing of psychiatric and substance abuse information. And I'm just wondering, as payers and providers, what your view on that is, and how can we get past all the discussion on that?
Maybe when I mentioned it was from an IT purity standpoint, it would be great to have the data, because if that data is hidden, somebody shows up at the ED and you don't know they're on those meds, that's a problem. So, I mean, I was speaking from a patient, from taking care of the patient perspective. The legal stuff in Connecticut, our HIE, the consumer advocate, is very concerned about that stuff, and it'll take us some time to work through that. It is very difficult.
We just run into a similar situation on that very topic. We're on the verge of adding to our website. We've shown claims for years, but we're putting together a specific thing we're calling the doctor visit profile, where it would show medications they've taken for the last year or two, the doctors they've been to, and the difference between this and DOBs is we're planning on showing the diagnosis, except for mental illnesses, and then we're leaving those off because they won't let us do that.
There are
You're so
cases,
stigma, it'd be fine.
yeah, it doesn't go quite far enough. When it talks about what we can provide, everything at the same time. You still don't know what the patient is doing or has done, whether they're taking those prescriptions properly. Those are the things that are missing in this equation. And a good portion of your readmissions come because they didn't follow instructions. It's not because of the failure of the organizations. It's a failure of the consumer.
Right. And you bring up, I mean, an interesting point. We get to a point where, you know, a patient's non-compliance actually begins to cost the docs, the provider, the payer, significant money. Is there going to be some kind of, you know, mandatory re-education for non-compliant patients in the future? I mean, if you're just not compliant with your treatment plan, do you get hauled into kind of, you know, I always think of this as like driver's school. You know, I'm going to beat the ticket by going to driver's school. You know, do I avoid the penalty by going to good patient school? I mean, we're going to have to provide education and specific incentives to some of these unique, hard cases, or are we just going to eat that like we do today?
Probably.
I'm going to make a bold statement. I mean, for us in the room, we understand that, but for the population as a whole, yeah, you're dealing with people with mental problems, and, you know, especially in an inner city hospital.
Right.
And I don't know if we would make much of a difference in that case. And I hate to be that blunt about it, but that's what we have.
Yeah.
Okay.
We have one more question from the audience. Please go ahead.
Yes, good morning. I've enjoyed your discourse this morning. We have a fundamental disagreement between the provider business model and the payer business model. I know my wife has tried to change me with incentives, disincentives, and it hasn't worked. What are the incentives for either of those models to change themselves to come to some middle ground in your views?
I would just start with that. I think one of the things that we've actually engaged with some of our commercial payers on is, and I'm sure you've heard of the gain sharing or shared savings component, where if we have a baseline that this is what it costs us to take care of these patients, and we put in some wellness prevention and these other measures to try to change that, and we come in below that, we get a piece of that savings. So I mean, it's a small start, but at least it gets us working with the payers in the interest of the patient, in the interest of care and quality and cost. But it's a starting point.